All right, our next two speakers will be coming up. We have Dr. Frances Tao, is a fellow in our primary care sports medicine for the current year. And she boasts a comprehensive medical background, including a residency in family medicine at UCLA, a master's in public health from Harvard, and a fellowship in Train New Trainers primary care psychiatry from UC Irvine. She's driven by a commitment to injury prevention, delivering exceptional care, and in doing so, she makes a consistent positive impact in her community. Dr. Small is a certified athletic trainer and sports concussion program coordinator at UCSF Benioff Children's Hospital, Oakland. She became a member of the Sports Medicine Center for Young Athletes team in 2012 and has been the athletic trainer at Berkeley High for more than a decade. After becoming certified in 2004, she attended A.T. Still University for a master's degree, where she began focusing on concussion education, evaluation, and management. And she's worked with athletes from youth through professional levels and enjoys helping athletes successfully return to their activities.
I guess I got my doctorate at some point in time. I'm not sure when, but hey, go me. So hi, I'm Lauren, and I'm the athletic trainer. I generally go by Lauren for just about everything, so yeah. Anyway, so we're going to be talking primarily just about the updates that have happened since the concussion statement came out in June of 2023. In regards to any changes that have been made, we're not going to really be getting a whole lot into like full concussion education, but primarily just changes that have been made for both of us. We have no relevant disclosures. So we are going to mention definition of sports-related concussion, updates on tools for concussion evaluation, considerations for adaptive athletes, updates to return to learn and return to sport protocols, and prevention strategies. This is the lovely picture from the when the consensus statement came out. The consensus statement was done in October 2022, and it was came out in June of 2023. So we're still going through and making changes and updates. So what is a sports-related concussion? This is based on the most recent consensus statement. And it is a traumatic brain injury that is induced by biomechanical forces. Essentially breaking that down, it's caused by either a direct blow to the head, face, or neck, or it can be elsewhere in the body that then causes an impulsive force to be transmitted to the brain. So that's like something like whiplash would be an example of somebody who could have a concussion even though they didn't hit their head. It initiates neurotransmitter and a metabolic cascade, which may result in axonal injury, blood flow changes, and inflammation affecting the brain. There is no abnormality that'll be seen on standard structural neuroimaging. So CT scans will be negative, X-rays will be negative. It's not something that is going to be seen on most of the scans that we would utilize in the emergency room, urgent care, that sort of thing. And it's clinical signs and symptoms of concussion that cannot be explained solely by drug, alcohol, medication use or with other injuries, but they may occur together. So it's possible that somebody may have a concussion and also be under the influence, and some symptoms may be from either or both. Okay, sorry. So updated tools for concussion evaluation. These are the latest. So we used to, for those of you who are familiar with the SCAT-5, Child SCAT-5, there is now, in addition to that, the SCOAT and the Child SCOAT, which are more for in the office setting versus the SCAT is more for in the acute athletic training room type setting. So there is a slight difference. CRT is the thing that would be more for officially like on the field at the time, trying to determine whether or not there is a concussion, not necessarily evaluating anything beyond what, if there is the possibility they may have a concussion. We're going to be doing, this is the on-field evaluation. Number one, we're looking at red flags. Obviously, if there are red flags, we're talking about activating the emergency action plan or whatever plan you have in place at your specific location. Red flags, nothing's really changed. Primarily, the thing is for also neck, head injuries that are more significant. So neck pain, seizures, loss of vision, loss of consciousness, increased confusion or deteriorating conscious state, so becoming more sleepy while they're sitting there, slowing their words, throwing up more than multiple times, or if their headache is the worst they've ever had or is significantly increasing as time goes on. Those would be time to call EMS or activate whatever your emergency action plan is at your site. Then there's the sideline evaluation. Not a whole lot has really changed in that. Visible clues, symptoms. Again, there are physical symptoms, emotional, and then also changes in thinking. So keep in mind that just because somebody may not have a headache, that doesn't necessarily mean that they don't have a concussion. Also keep in mind that they may not have symptoms right away, but then as adrenaline comes down, as things kind of calm down, sometimes it can be hours or possibly even days afterwards, they may start exhibiting symptoms. So they may be like, I'm fine, but have had a significant impact or potential event. There may not be things that they notice right away. And oftentimes this can be where it can be very tricky because they're saying they're fine, they want to go back in and play. Their coach is like, but they're fine. Reality of the situation is you do need that time to let things calm down. It's always safer to err on the side of caution. Asking them questions like, do they know where they are? Do you know who scored last? Generally speaking, a lot of the original Maddox questions, a lot of teenagers don't know things like days of the week and months of the year much anymore. It's very strange. But so keep that in mind. I had somebody ask a kid who the president was. They didn't know. I mean, you have to kind of gear it towards the population that you're working with and things that you know they would know versus what the actual questions are. It has less to do with the specific questions and more to do with just kind of the idea of, do they know where they are in place, time, that sort of stuff. When in doubt, sit them out. And the key reason for this, in addition to we don't really know, is that if they may have an injury, is that if they are removed from play sooner, their recovery is shorter. It is less complex. There is less likelihood of them missing nearly as much school, missing nearly as many games. So those are reasons why missing half of the game, missing the rest of the game today is going to be significantly better than going back in, getting a second hit, and all of a sudden we're looking at weeks, if not months, of recovery. So, and that's what studies have been showing lately. So key thing, especially if you're having to have an argument or discussion with the coach, parent, that sort of stuff, it's, hey, we can remove them now, potentially wait, not play the rest of the day, but then they'll be able to be ready sooner than if we see what happens, let them go back in and then they get hit again. It's also important to understand with California state law is that if we suspect they might have a concussion, they're removed for the day, period. It doesn't have to be that they have been diagnosed with one or that there have been indications that they do have one. It's if we think they might have one, they're out. And a lot of times coaches and things like that forget that part of the law.
All right, so I'm going to be talking about the SCAT-6 and the SCOT-6. The SCAT-6 is predominantly used for those who are at least 13 years old and older, whereas the child SCAT-6 is used for those 8 to 12, and we don't really have a good tool for those under age 8. But for the SCAT-6, you really want to use this within the first 72 hours of a concussion, okay? And the new guidelines actually also included these optional components, which they'll be highlighted in orange. And so the first component of the SCAT-6 is actually essentially the concussion recognition tool that Lauren just explained to us. Observable signs of concussion, a brief evaluation of their neuro symptoms, as well as their memory assessment. And once you pull them off the field, where it's a little bit more quiet, you can then do a deeper dive and do a more comprehensive evaluation, perhaps asking first about their history. So have you ever had a prior concussion? What was your recovery course like? Do you have history of learning disabilities, of mental health disorders such as anxiety, depression, ADHD? Do you have history of chronic migraines or headaches, right? Because these can all kind of muddy the picture a little bit. And then you evaluate their symptoms and their severity of symptoms so you can get a good assessment of where they are in this moment in time and use that to therefore track how they're progressing during their recovery process. You might assess their cognitive screen with the SAC, or the Standardized Assessment for Concussion, looking at orientation, immediate memory, concentration, and then evaluating their coordination and their balance, so the modified BES or MBES, and then timed tandem gait. And then after at least 5 minutes have elapsed, then you go back and test their delayed recall. The optional portion of it is your modified BES, testing your balance on a foam pad, and then dual task gait, just to kind of increase the ante and make it a little harder for people who go through these evaluations frequently. But what about if it's been beyond 3 days, right? They're presenting to your clinic a week later. Then really you want to use the SCOT-6 or Child SCOT-6 for the younger kids. And so the recommended guidelines are in green and the optional components will be in orange here. And essentially it's a multimodal assessment of various symptoms and presentations for a concussion athlete. And you might not do all the different components in your session with them because, let's be honest, it takes quite a bit of time. It's important to just pick and choose, and then what you're concerned about, you might follow up and then take some more time in your next visit to then do that evaluation. So what I'm really excited about is that the updated guidelines now incorporate components about mental health and sleep, because we know that concussion can, also have that component as well. And so they are screening for depression and anxiety with the PHQ-2 and the GAD-7 respectively. And they're also screening for sleep disorders now, because we know that concussion can impact sleep. I know the text is really small, I'm sorry. It's a really long form, but this is an example of the symptom score. And so there's a list of 22 symptoms that we frequently see with concussion, and you'll have your athlete rank each of those from a severity score of 0 to 6, 0 being none, 6 being the most severe. And then you add all those scores together and it gives you a total score out of 132. Right, so if you're at 132, then you're like, dang, your concussion is really bad. But if it's lower, then perhaps a milder concussion. And what's neat about this is that you can reuse the same evaluation tool over a period of time and track to make sure that their symptom severity and maybe even the variation of their symptoms are getting better with time. Now for our cognitive test, the updated guidelines have essentially created some changes to make it more difficult for people. The reason behind that is that there was a ceiling effect in the past versions where if you've done the concussion test a couple times, you basically know all the answers, right? And so the first one is to test your immediate memory. The old guidelines just provided a 5-word list. And again, if you've heard 5 words, you can probably remember those. These lists are now a list of 10, so it just makes things a little bit more difficult. We also have digits backwards. So you would read your athlete a string of numbers and then have them repeat it back to you in reverse order. So for example, if I say 719, you respond 917, right? I guess them to just think a little bit longer. And what they've done with this one is they've increased the total number of numbers in the string. So we went from 3 to 4, 5 to 6 as the max. The next one is the months in reverse order. So starting from December, can you recite the months in reverse order all the way back to the first one? What they've added for this one is actually a timed component. Normal is under 30 seconds for them to recall all of that. Now, a physical exam should also include a C-spine exam and a neuro exam that tests your cranial nerves as well. But what they've added here is actually orthostatic vital signs. So now we're checking for blood pressure, heart rate, and symptoms when we're going from supine to standing after a minute. And I briefly mentioned the modified BES to test for your balance. And here we're really testing your non-dominant foot. So if I kicked a ball towards you, which foot would you kick instinctively with, right? Let's say they answer right. Okay, well then we're gonna test your left foot. So there's a couple of stances, and so you'll see the top 3 images. The first one on the left is a double leg stance where you just have them stand pelvic width apart, hands on their iliac crest, and then closing their eyes. And then for each of these stances, you're testing about 20 seconds and counting the number of errors that they have. The one in the middle is a single leg stance, so standing on your non-dominant foot only and balancing there. And then the last one on the very right is your tandem stance, where you have your non-dominant foot in the back. And again, checking for your errors there. Again, if you wanted to up your ante, you can have them do it all on a balanced foam pad. This might be a really good tool for those who have a better balance at baseline, such as your gymnasts or your dancers, right? Compared to your football players that might not need balance as well. And then our timed tandem gait. So you would essentially place a 3-meter piece of tape on the floor and have them do tandem gait all the way across and all the way back. But again, you want to time this and do it for 3 trials and see what your average and fastest times are. Next is our VOMs. So this is testing vestibular ocular motor screening. Dr. Schumacher did an excellent job earlier explaining and having us all practice during the workshop. But before you get started, you actually want to ask your athletes what baseline symptoms they have between the 4. So headache, nausea, dizziness, and fogginess, and have them essentially tell you their severity score at the start. Then you do your battery tests, right? Your smooth pursuits, you do your saccades, kind of looking back and forth in 2 different directions. You do your vestibular ocular reflex, where you hold here and then move their head and keep their eyes focused on the finger, as well as your visual motions sensitivity, where they have their hands out and they're twisting at the waist and kind of following and tracking their eyes, right? And after you're doing each of these tests, then you ask them again, how are your symptoms? How would you rank them, and see if they're increasing? And last but not least, our delayed recall. So can you recall back those 10 words we were saying earlier? How many can you get right? And you want to make sure, again, that there's been at least 5 minutes that have elapsed between your immediate memory test and your delayed recall. A brief note on just interpretation of the visual ocular motor screens. So those people who do not have a concussion actually have very few symptoms after this test, right? So it should raise an index of suspicion if they're testing positive. And the ones that have the highest predictive value for concussion is actually the last 2. So the visual ocular reflex and then the vision motion sensitivity. And as you can see, the sensitivity and specificity aren't great. There's a huge range, but what researchers have actually shown is that if you are doing the VOMs in combination with other tests that we've talked about, that's what's going to increase your sensitivity and specificity for a diagnosis of concussion. There are a ton of other optional components as well, so those are the ones that are highlighted in orange, and we won't really be talking about them today. I'll say in my practice, I actually don't use them very regularly. I find that with all the other ones that I have just mentioned, it's quite sufficient, but just ones for you to consider. And at this point, I do want to just do a little plug for our adaptive athletes in our communities. So these are athletes who have some form of disabilities. They've adapted their sports to what they're able to do. And so this is the first position statement that came out for the concussion para sport group. And they just wanted to point out that kids with disabilities might actually benefit from baseline testing compared to other athletes just because of the variable nature of their disability, right? You think about their baseline cognitive function, their visual and their physical capabilities. And because of that variability, when they have concussions, they might actually have very atypical presentation of concussion, right? So how would you know that they have a concussion if you don't know what their baseline was? In general, though, more research is needed in this field because there's just not a lot out there. And it's important to know that the concussion tools we talked about are actually not validated in this population. And so this paper and their appendice tables actually has specific considerations for concussion evaluations depending on athletes of various types of disability, okay? So the green boxes are saying based off of current guidelines, we wouldn't make much change. The yellow is these are the changes we would make for this particular group. And then the red is we wouldn't do this at all for this group. So just for an example, we have on the very left, this is a group of individuals who have impaired muscle power from spinal cord injury. And so the next column over says, remove athlete from play if you're worried about concussion. That's green, meaning no change from any other athlete that you would have. But the next one over is when you're thinking about the initial brief period of rest, both in terms of physical activity as well as cognition, you might make different recommendations if this athlete is a manual wheelchair user, right? If you're thinking about what needs to be involved for them to propel themselves forward or to do independent transfers, that's an extra physical component that we're not normally thinking about. So anyway, I bring it up just so that you're aware that this exists. All right, so how do we return to learn and sport? Well, there's really those two components, right? So return to learn is returning to pre-injury level of learning activities without any new accommodations. And return to sport is really completion of our return to sport strategy. And I'll just briefly mention that the updated guidelines now talk about how a small and brief increase in your symptoms as you're trying to do these things and trying to move towards recovery is totally okay. What I mean by that is, let's say I'm at home and I'm reading a book for about 15 minutes. If I started with a headache of a pain severity of, let's say, 2 out of 10 before I started, and after 15 minutes of reading, it bumped my symptom severity from a 2 to a 4, well, that's only a 2-point increase in symptom severity, right? That's totally okay. But if it's going beyond that 2-point mark, or your symptoms are lasting beyond an hour, that's an indicator that maybe I've done too much and I need to scale it back. Does that make sense? Okay. So in brief, I'm going to talk about return to learn, and Lauren's going to talk about return to sport. But we've got these extensive tables which can appear quite overwhelming, but we'll break it down here. So initially, with their first step, we really just want them to get back into activities of daily living after concussion. As they're feeling better about that, you can slowly start to get them back into school activities by increasing tolerance of cognitive work. This isn't to say they need to go back to school quite yet, but they could be doing homework or reading at home outside of that classroom setting, just because there's less stimuli that could impact their symptoms. After that, we move to school part-time, and the idea here is to increase academic activities with gradual introduction of schoolwork, and I'll talk about accommodations in the next slide. And then, of course, the end, returning to school full-time because they are students first before they're athletes, right? And so to briefly talk about academic accommodations, we really want to break that lazy athlete stereotype. And so in terms of what accommodations can we give them, well, there's quite a few. You can talk about reduced attendance for the first couple of days, just to give them a chance to recover. You could increase the amount of breaks they get throughout their school day if they're going to school part-time to reduce that stimuli that might be worsening their symptoms. You could talk about giving them a postponement or increasing their time for turning in schoolwork or for testing or making alterations in their physical education courses. And then on the right here, I know it's, again, super small, but the CIF is the California Interscholastic Federation. They're the governing body for sport in California for high school level. And they do actually have this checklist for providers to use when you're thinking about what accommodations, and it just makes it really easy to checklist your way through to finish your visit. And so this kind of brings us to then the physical component, right? Rest versus exercise after concussion. And it is no longer recommended for people who are worried about having a concussion to cocoon in a dark room. That actually has been shown to not be effective in the recovery process. And what we should be doing is actually starting to encourage light intensity physical activity, because that actually helps improve recovery faster. So again, using that 2-point scale, if it's a subsymptom aerobic exercise, it can actually be started pretty safely, and you might see improvement in recovery time by about 4.5 days, which is not insignificant. And we can also consider individualized heart rate-based activity based off that max heart rate we talked about, and that can reduce your risk of prolonged symptoms beyond 4 weeks.
Okay, so similar to the return to learn in terms of not being quite so afraid of symptom increase, it's the same way with the return to sport as well. It is important that, as Dr. Tao just said, that we start exercise earlier than we originally than we did prior because of the increased blood flow. It gives a distraction. It's good for them to get out and be doing something as long as it's not significantly increasing their symptoms or decreasing their risk of another head injury. So the goal of the graduated return to sport, there's 2 parts of it. One is that we're trying to promote early symptom-limited physical activity, and then also that we are checking to see if symptoms increase as they are beginning a return to sport. If they are significantly increasing, then that's telling us they're not quite ready to be returning to contact-based activities. So this is, again, super small. We're going to kind of go through a little bit smaller. So initially, they're really just supposed to be limiting to symptom-limited activity. Things like going for a walk, helping load the dishwasher, like all those sort of things that are activities, but not anything that is super strenuous is what they need to start out with. They should be doing that about a day to 2 days after they would get their injury. They should not be waiting much longer than that because it actually can make their recovery last longer. Then there's the aerobic exercise. They can start doing this while they are still symptomatic, and this is the big change. They do not have to be symptom-free before they can start aerobic activity. It's limited based on how much their symptoms increase, and there is based on heart rate, like your heart rate max. It's also going to be broken up based upon healthcare provider guidance as well as local laws and sporting regulations. So different states and different clubs, sports have different rules, which may cause things to be more steps or less steps or whatever, but it's based, so that's partly why it's based upon, like everybody's a little bit different state-wise. There's then individual sport-specific exercise. This is stuff like going and kicking a ball around, working on their touch, shooting goals with nobody else around, those sort of things where there's, again, a very, very, very decreased risk of them getting hit in the head or somehow injuring themselves again. However, they're able to start doing things like running, changing directions, moving their head, all that sort of stuff. This is the last step they can do and still have some symptoms. They must be symptom-free before they progress past this stage. But again, they're given a lot more activities that they can do. After that, they need to have clearance, or it's recommended that they have clearance. If the state of California, they need to have written clearance to be able to start even non-contact training drills if it's involving other people. So going to practice and working on your touch in soccer or playing catch with a sibling, that sort of stuff, that should be done after they've had medical clearance. And then there's full contact practice after that. At this point in time, they're pretty much doing everything but gameplay. And then finally, return to sport, which is when they're allowed to do everything. So there is more that they can do before they get cleared, but then there's also a lot of stuff that they should not be doing until they get that medical clearance to make sure that they're doing okay. California, there's the state law that return to play cannot be sooner than 7 days after an evaluation by a physician who has made the diagnosis of concussion and only after completing graduated return to play protocol. Key part of this is if you are seeing a patient in your office, making sure they're understanding that we have written clearance, but you still need to do the graduated return to play. So it means we're giving you clearance to start that or to continue that, but you're not going to be playing in a game this afternoon. And making sure they understand that there are multiple steps in between to make sure that they are actually fully recovered. Also, making sure that the clearance is in writing, especially if they are a high school student or a student that is a part of a club or anything like that. There needs to be written clearance saying Johnny is okay to begin contact practice again or to continue return to play protocol. They are not allowed to start with the team until that happens. And then finally, there should be a certified athletic trainer, physician, or identified concussion monitor with whatever club, school, whatever, that should be checking off on them every day to make sure that they are actually completing these things and that they are in fact symptom-free. And then coaches are supposed to have training every 2 years. That's nothing new, but yeah. There are currently forms that are being developed. They are not approved yet, but they will be approved soon, and they will be on the CIF website. Key part, this is what the kids are always asking, when can I play again? You have to return to pre-injury learning activities without new academic support or symptoms. And you have to have successful completion of the return to play protocol before you can have unrestricted athletic participation. So they cannot still be having accommodations in school and be allowed to play in games. Student is first.
All right, so what about prevention strategies? Well, there's been a couple of things that have been shown to decrease our concussions. First one being rules and policy changes, and so disallowing body checks in adolescent hockey, for example, using mouth guards in ice hockey, reducing contact sports in American football, and then also incorporating neuromuscular warm-ups for rugby. The evaluation of headgear, however, in non-contact and collision sport actually requires more research. So this is a summary of kind of what we've talked about today in our short session together. And if you've taken nothing away from our conversation today, I hope you at least save this QR code. Not only because I worked hard on it, but it has our references, and actually it has links to all of the updated concussion tools we talked about today. It also has the CIF links as they currently exist, but as Lauren pointed out, those links will be updated in the near future. Thank you.
Thank you very much. We will have you all come up real quick and take a seat at the table for Q&A. So if anyone has any questions for our speakers, we would love, after you get the QR code, to hear from you.
I always have questions, so that was very helpful. As a primary pediatrician who sees a lot of younger kids that aren't necessarily super elite high school where there's going to be athletic trainers to sign up. So I have two questions. One is, I have a limited exam, I have 20 minutes. How am I going to, what would you selectively choose for high yield, aside from, headaches, big constitutional ones? And the other is, if you have someone who's not in the competitive sport but wants to do return to play, do I have a parent? How are we checking that they're not more symptomatic and they're not going to come to me or do that?
So, is this on?
Yeah.
It's okay. So I think, you're right. We have very limited time in our clinics to do these evaluations. So if it's that very first visit, again, trying to focus, depending on timing, whether it's your SCAT-6 or your SCOT-6, right? I would definitely dig into that history, because that's going to impact a lot in terms of giving you ideas about prognosis for recovery time. You would do your basic C-spine neuro exam. And then personally, I like doing the VOMS testing for eyes, just to see where they're at baseline. Now, in terms of screening for depression, anxiety, I might actually push that off to a separate visit. I might also do orthostatic vital signs at a different visit as well. Although I'll say at the collegiate level currently, the NCAA does require orthostatic vital signs to be incorporated within that first visit. I think aside from the VOMS testing, I might also just do the balance testing just to have a good baseline. And then based off of that first assessment, right, if you notice that anything was abnormal, then you can make a note of it for your next visit and to repeat that and see if it gets better. Like, was it a fluke on that one day because they were just tired and they weren't sleeping well? And then kind of go from there. And then your second question, I think, was asking about if they were not really a high level athlete, and was it just to see if there's anything different that I would do, or?
No, it's just for return to play, you're saying if they successfully do something so they can advance, then their last line said it has to be signed off by a trainer or a coach or somebody. So if those aren't available, who's doing that to say yes or the next level?
Okay, so every school should have at least an athletic director. So if they don't have an athletic trainer, that's probably their concussion monitor at school to sign them off in their progression.
And I have problems serious studies. I probably said to them, could they do this last week before? And they're like, no, they're bad at math. So I just got all those things that were very funny, because that is unfortunate.
Yeah, I would just mention especially with the kids, is if they're part of a club team, then there is some sort of a person that is part of their club that also is part of their job is to kind of coordinate all of those different things. Their coach can be somebody that can help with this. It is more just them making sure that they are just not doing it on their own and saying they did it and not actually doing it, and understand that there are steps they need to follow more than anything else.
Yeah, I just wanted to add, I know it's really challenging to do all that stuff in primary care clinic, and when I was in primary care clinic, I think one of the most helpful things, a part of those tools, is actually looking at that symptom score, right? And that's not something that you have to sit there and go through and read one by one to the athlete or the patient. You can have your staff give them that form and they can fill it out when they're in the waiting room. And that really helps you, one, get more objective data on their symptoms, then you can see what their symptom burden is, right? So when you're following up with them, Are they getting better, like what Dr. Tao said, yes or no? And then what sort of symptoms are really predominating, right? Is that their headache that's really lingering and all the rest are better? Or is it more of the concentration or vision? So I think that one of the most helpful things that doesn't require your time that the staff can do is that symptom score.
This is a short question about the wearables. So you were mentioning in I think it was a ring that some of the athletes were wearing, and it monitored their heart rate, their respiratory rate, and their heart rate variability, and that led to the possibility of predicting COVID. I'm assuming you ended with COVID just because it was done during the pandemic, but I'm assuming it would have no differentiation between influenza or any other upper respiratory type illness type thing.
Yeah, you're exactly right. And I think that that's what the Department of Defense is looking at, right, for the military personnel to see whether or not these wearable devices, whether it's a ring or a wrist-worn one, that's a tongue twister, can predict when they're going to get sick. And so they've invested $10 million into this other program that they're using to look at that specifically for them. Yeah, so not just for COVID, but for other respiratory illnesses as well. Great question.
I have a question for each talk. The first one is with the wearable devices, are we now seeing like people having skin reactions to them, or are we seeing a new rise in skin stuff because we're putting all this stuff on our skin, right? And then for the concussion talk, as a general pediatrician, there's always been all this stuff out for the athletes and the older kids, but you get the toddler who had the big head bonk. Just general recommendations for those that have to care for those kids.
Yeah, I think, like with anything that you wear, whether that's jewelry, clothing, or otherwise, you can get some sort of contact dermatitis associated with it. And I have seen some cases, and I've heard personally of some friends or colleagues that have gotten reactions to different bands or rings. So I think that that's something to definitely consider. The ones that have done it, if they're really into looking at their data, then they actually just get a different thing. So if they wear a wrist-worn one, then they'll try a ring or they'll switch around. And that's a nice thing because there's lots of different types of devices out there.
Yeah, I don't have any great tips for the young ones, unfortunately, because these tools that we talked about today really doesn't go younger than age 8, right? And part of it is if you ask a 3-year-old to recall back 10 words for you, it's not gonna happen. So I think a lot of it's going to be based off of the primary caretaker of this child, right? What are their normal behaviors, what are not? Can they even voice that they're feeling uncomfortable, and how would they even explain that in their phrases or words that they have?
Also, how can we restrict their activity? Like it's hard to restrict toddlers.
Agree. It's very hard to restrict toddlers. Just even thinking about fractures, for example, right? If they're feeling fine, they're going to be running on it, even if they have a cast on. So it's very, very difficult. It's about being patient and kind of, again, just knowing what their baseline behavior is. And if there's anything that's kind of outside that realm, just getting them plugged back in and getting reevaluated. And you're probably at that point, your exam and history is going to be the most important in terms of your neuro exam. If you can do some of that neuro exam, and then your palpation skills, right?
I do know that we, a few years ago, created a version for the younger kids that is part of the discharge instructions if they go to Children's Hospital for after hitting their head. There is actually a document that was created. I don't remember, I know that they get it with the printout, but I'm not sure how else to be able to access it. That's definitely something that is out there. I'm just not 100% sure how to get it. So that's what I know we did create one because we made one for the school age kids, and there's one for when they're not quite school age. And I'm not sure where that lives, but that is definitely something that we have somewhere. I'm sure we can try and figure out a way to maybe get it added to the QR code if I can find it.
And I think maybe one last spot is just in terms of screen time, because lots of kids get put in front of an iPad, etc., for distractibility purposes. Like if you're out at a restaurant, we actually recommend reducing screen time just within that first 48 hours. So that's perhaps something we can use with that younger population too.
Yeah, and then I'll also say too that a lot of the tools that were presented are really just for sports-related concussions. The same principles apply, but at least in our referral criteria for both of our concussion clinics, both on the West Bay and the East Bay, they have to be involved with some sort of sport. And then if not, it gets routed to neurology. So like pediatric neurology will usually see like the younger kids that fall and hit their head. So I think a lot of these tools, it's important to keep in mind it's for more sports related concussions because that's what the concussion in sports group designed them for.
Thank you very much to all of you.